Hi, everybody. This is a short conversation on antiemetic drugs, and it should augment what is in the textbook, but it's what I believe is the most important antiemetic drug conversation to have with you. So please utilize this as your starting point for learning these medications. So there are several classes of antiemetic drugs available, and what they do is they antagonize the neurotransmitter receptors that are known to be involved in the physiology of nausea and vomiting. The antiemetic drugs are classified according to their primary action. Keep in mind that some agents affect multiple receptors, which can make this a little bit challenging to sort of pare down in your head. So there are 5 neurotransmitter receptor sites that are of primary importance in the vomiting reflex. And that is the M1 muscarinic, the D2 dopamine, the H1 histamine, the 5 hydroxytryptamine or HT3 serotonin receptors, and the neurokinin NK1 receptor, which is substance P. So believe it or not, there isn't a lot of published data to really support how and which antiemetics work best in what types of situations. So again, when I say which types of situations, I mean, is this post-op nausea and vomiting? Is this chemo-related nausea and vomiting? Is it gastroparesis-related nausea and vomiting, et cetera, et cetera? So we're going to go through these agents. I'll tell you which ones I use the most and why I use them, what the side effects are, but we don't have a lot of really solid evidence-based practice with these drugs. It's kind of just empiric. This is what we know works well because we use them a lot. And here's the agents. There's anticholinergic agents, antihistamines, yes, like Benadryl, dopamine receptor antagonists, serotonin receptor antagonists, neurokinin receptor antagonists, the glucocorticoids, cannabinoids, and then the benzos, okay? So of the anticholinergic agents, there's just one that I really want to mention, and that's scopolamine. It's an M1 muscarinic receptor antagonist for antiemetic use. Really, it's what is used as a prophylactic against motion sickness. Now, I will tell you, if you're old enough, like I am, to have worked with cancer patients 20 years ago at least, we did use scopolamine patches prior to Zofran being available for certain cancer patients. I don't see that used very often at all anymore, but it is technically something that you could do. In terms of the textbook answer, we use it against motion sickness. It's a transdermal use, 1.5 milligrams every 72 hours. And the side effects would be those anticholinergic side effects like dry mouth, drowsiness, vision disturbance, etc. So, not really an easy drug to use chronically because of those side effects, and not one that I would recommend really outside of motion sickness. Another set of drugs that we really think of as being used for motion sickness as well as scopolamine would be the antihistamines. Um, and again, we're talking about drugs like meclizine, Benadryl, promethazine. I just listed out standard doses for adults there. Obviously, you're going to back it up much more for your pediatric population, depending on size and weight. Always remembering that just like scopolamine with the anticholinergic agents, sedation is the common side effect. So again, these aren't drugs that can be utilized easily for somebody who has a more chronic nausea and vomiting type syndrome. So there are 3 different classes within the dopamine receptor antagonists that can be utilized for nausea and vomiting. Phenothiazines, butyrophenins, the phenones, and then the benzamides, okay? Benzamides are going to be like metoclopramide, Reglan, okay? So let's go through those separately because they deserve a little attention, each of them. So let's just go through the phenothiazines. Now, phenothiazines were the first group of drugs to demonstrate any substantial activity in the prevention of chemo-induced emesis. So we're going back quite a few years here. They act predominantly by antagonizing the D2 dopamine receptors in the area um, postrema of the midbrain, but they also have an M1 and H1 histamine blocking effect. So this is where they hit up on several of those receptors like we talked about. Now remember, these early drugs, anytime we're talking about early drugs in any classification of drugs, these are generally the ones that maybe aren't as specific, don't work as quite as effectively as newer drugs. That's the case with these. And that's why, quite frankly, I don't have much history using these drugs at all, because since I've been practicing, we've had newer drugs out, which we'll talk about in a moment. So just to let you know that the first drug listed, the name you might have heard is Compro. Um, Chlorpromazine, I think is used less often than Compro, but even so, we don't utilize these drugs too much. They are antipsychotics. We tend to see them in more of maybe a migraine, nausea, vomiting sort of situation. Um, Compro, prochlorperazine, perhaps you will see it listed in the textbook as for gastroparesis, but it's not really a medication we do use for that. I will say the other thing you have to worry about with these drugs is the antipsychotic side effects for long-term use, which would be extrapyramidal reactions such as dystonia or tardive dyskinesia. So again, there's long-term concerns with using these medications. So similar to the phenothiazines, the butyrophenones, which is droperidol and haloperidol, were used much more frequently prior to us having medications like Zofran. They are major tranquilizers that potentiate the actions of opioids and have an antiemetic effect when you use them alone. They're primarily used as a pre-anesthetic agent or for procedural type sedation, but they can also be effective for post-op nausea and vomiting. So it's kind of a double, positive scenario there. Droperidol is a short-acting drug. It's given in a dose of 0.625 to 2.5 milligrams IM. Haloperidol has a considerably longer half-life, which we know, of about 18 hours, which is really going to limit its half-life. Really going to limit its ability to be useful because of the half-life, Side effects are similar to the phenothiazines. And there is a dose-dependent QT prolongation and torsades in people who, already have a potential for those cardiac abnormalities. So again, we're not seeing these as often, but they are technically still listed under these categories of antiemetics. So the class of medications we're going to talk about next is benzamides. There are actually 3 benzamides that we could be talking about. I'm going to focus on metoclopramide, but there's also trimethobenzamide and domperidone. We use both of those even with more caution than we use metoclopramide these days. So I'm going to just focus on metoclopramide. Metoclopramide causes central and peripheral dopamine D2 antagonism at low doses and very weak 5-HT3 blockade at the higher doses, which would be used for, emesis that would be caused by chemotherapy. So again, so if you're trying to treat somebody for chemo-induced emesis, you're really having to give them a pretty hefty dose. It's at those hefty doses that we started to see the side effects of this drug. And now, even in lower doses, people are a little reticent to use it long term for things like gastroparesis, which is what you would use it long term for. So this is because, let me just say this. It also stimulates cholinergic receptors on the gastric smooth muscle on those cells and enhances acetylcholine release at the neuromuscular junction. So that's why, because of what it does, how it works on gastric smooth muscle cells, That's why it's effective in not just treating nausea, but also gastroparesis, which is, if you look at what that means, gastroparesis, slow moving stomach, okay? And it also increases tone in the lower esophageal sphincter, which helps with reflux and nausea related to reflux. Okay, but here's the thing. Um, Metoclopramide obviously crosses the blood-brain barrier. So what happens is um, we see a fairly impressive, um, with higher doses, central side effects such as anxiety, restlessness, depression, um, QT interval elongation. And then we also can see, because of it crossing the blood brain barrier even more so, we see things like neurologic side effects like the akathisia, dystonia, the tardive dyskinesia, like that lip smacking, in the elderly with high doses. So let me just put this in the context for you. Let's say 20 years ago, I was practicing gastroenterology. This was the only drug we had for gastroparesis. It kind of still is in a sense. We would maybe give everybody 10 milligrams 4 times a day, before meals and at bedtime. The reason being was we wanted to stimulate the stomach to start working before food hit it, and then it would help empty the stomach. We were using it judiciously, if you will, and now we saw some of those neurologic side effects like the tardive dyskinesia and things like that, and people really backed away from it. I still use it. It still works. I might start with somebody with 5 milligrams, just AC, and see how they do. But in things like gastroparesis, we don't have too many options. Yes, there are things like gastric stimulators and pacemakers. You don't just get to walk in to Temple University and ask for a gastric pacemaker. It's a long, arduous process, and not one that necessarily works either. So sometimes these patients are so sick, this is the only type of medication that really works for them. So again, I just say you want to be careful in the elderly, and you want to start with lower doses as much as possible. So then we have the serotonin receptor antagonists, and specifically we have the 5-HT3 receptor antagonists, which really have cornered the market when we think about antiemetics. And the one that we think of more than anything else is Zofran, which is the top drug listed. And then all the drugs in that class can certainly be used. But I think if you're somebody coming from a hospital type atmosphere, just like with Protonix, you're going to see Zofran being utilized the most. And really, the indication for the 5-HT3 receptor antagonists, again, like I mentioned, I can remember treating, patients with antiemetics prior to these drugs for chemo-induced emesis, and nothing worked like Zofran. We would pre-medicate with all these other drugs that would leave patients just so completely groggy they couldn't function, and they really weren't as effective. So when Zofran came out, I'm going to say it was somewhere between 15 to 20 years ago, it was really quite a marvelous drug for those of us who worked in inpatient oncology related fields. It was also extremely expensive and extremely limited. It certainly isn't anymore. So with that said, how do these work and what do they do? I mean, they really are the cornerstone of therapy for the control of acute emesis with chemo, but also we certainly use Zofran outside of that. It's exceedingly easy to use the 5-HT3 receptor antagonist. It's sublingual. It makes it very easy. In terms of, is there anything that you should know in terms of negative side effects? Mild headache is the most frequent adverse event, if you will. About 15 to 20% of patients, they really do get a headache from the 5-HT3 receptor antagonist. There was 1 or 2 studies that showed perhaps an hour or 2 after getting Zofran, for instance, or it could have been with granestron, one of the 5-HT3 receptor antagonists, that there could have been a potential for an EKG change. Quite frankly, I don't think that's really stopped any of us from utilizing the medication. But you should always be looking for electrolyte abnormalities in these patients with nausea and vomiting, and maybe that's actually the situation at hand, to be causing some of the type of bradyarrhythmias or whatever it was that was being described. Um, Zyprexa is actually the olanzapine drug on the bottom. So that's a serotonin receptor antagonist that actually is listed as an antiemetic. Now, I have to be honest with you, I've never used Zyprexa once in or thought about it until probably this lecture for anti-emesis. However, if we're being fair to all drugs, it is listed. It is a second generation antipsychotic, and it blocks serotonin, not 5-HT3, but 5-H2 receptors, as well as dopamine D2 receptors. And again, could be utilized with somebody who maybe fails the 5-HT3 receptor antagonist, but not something that I would go to firsthand. Okay, so but it is listed in the category. I'm going to keep this slide fairly short, and just mentioning that glucocorticoids are also on the list, specifically dexamethasone, in terms of being what is considered an effective and well-tolerated antiemetic for chemo-induced emesis. Again, the mechanism of action here is a little bit misunderstood, or not really well understood at all. We do know that the side effects would be classic of glucocorticoids, so that would be insomnia, increased energy, and mood changes are the concerns with using these. As single agents, you can see glucocorticoids being used prophylactically with, some mild emetogenic chemotherapy, but sometimes you'll see glucocorticoids being combined with a 5-HT3 receptor antagonist in some certain chemotherapy protocols. So things like cyclophosphamide, cisplatin, those chemo agents, sometimes you'll see a combination of glucocorticoids and 5-HT3 receptors. And again, I'm not going to get too far down into that discussion. Just know that that's a possibility for some of the oncology patients. So cannabinoids, marijuana. Certainly we've known for many years that there is usefulness, and it's finally taking effect in terms of medical marijuana. I'm not going to get into a full conversation about medical marijuana. I just listed nabilone and dronabinol as two sort of popular options for especially chemo-induced type emesis. But we certainly know that marijuana can help those same cancer patients increase their appetite, and it's finally getting traction in terms of making sure that patients have these options. So again, that's sort of a whole nother conversation of when and how do you prescribe medical marijuana, and we can have that conversation at another time throughout your specific courses, because it's going to be very different depending on which track you're in. But again, don't forget the usefulness for certain patient populations. And lastly, benzodiazepines. So sure, lorazepam and alprazolam do have an antiemetic type effect, but again, their side effects are fairly impressive, and they're actually, as a single agent, a fairly weak antiemetic agent, to be honest with you. Sometimes they are given to reduce more anxiety and anticipatory emesis, more than they are to really treat as an antiemetic. So again, not seen in any sort of regularity like we would see the 5-HT3 medications. So With that said, that's all I have for antiemetics, and please let me know if there's any questions.